Thank you very much for the invitation. First, I have to apologize for the people in the audience that would expect from me to give recommendations, evidence, etc. Because the duty for us, for our group, was very specific to speak about optimization, amount of fluids, and there is very little evidence, and there is some, of course. And so I could summarize our conclusions in one slide, and I will leave. So I prefer to give some background, theoretical background, and also I feel that it's democratic to show to everybody the ambience and the discussions, because they were very rich and passionate sometimes. And I want to transmit this, all the background, and end up with what we will provisionally recommend, because as they said, this is a preliminary statement. When I was young and naive, I followed very much, when I was a resident, the recommendations from at that time from Will Shoemaker and Dennis Edwards, that as you see, this was part of our history in intensive care medicine. Fill the patient until A valves explode or something like that, or keep them dry and watch them die. So this is what I was taught and I practiced it during my early years. But of course, we have now different concepts. Resuscitation in general is the active macrohemodynamic manipulation to restore tissue perfusion. This is the duty. And of course, when we speak about optimization, we have to know that the first rule is probably to stop resuscitation, this active manipulation mainly with fluids, when we think, we guess, we assess that the perfusion was being restored. This is the only way to avoid over-resuscitation and the risks of fluid accumulation or fluid overload. And this is all about coupling, as I said yesterday in another talk, coupling macrohemodynamics to perfusion. And the fluids are fundamental actors, of course. And I think one of the most relevant concepts or new concepts in the last decade has been this categorization in phases of fluids administration during resuscitation. And I love this because it puts you in the context when you are thinking about patient, in which phase you are, and we now have the duty to assess the optimization phase. And in part, the optimization phase is in the ICU. Probably the patient was fluid loaded initially in the emergency department, in the OR, or everywhere, elsewhere. And I think the key action for optimizing fluid administration in the ICU, unless there is an emergency and a collapse, sudden collapse, in general, you have time. You put central venous catheters, arterial lines, etc., and you give the fluid challenge. The fluid challenge is the key aspect of optimization. And this, as you know, it requires a target. It triggers, of course, for giving fluids, which usually is tissue hypoperfusion in this context, a fluid challenge. If the target is not achieved, then you go to assess safety of the intervention, and then you again assess fluid responsiveness, etc. This is what we think actually. But this slide is probably the most important that I will show, besides the final about our recommendation. We have the problem when we speak about optimization or individualization is very complex problem. It's like the Everest climbing. Because first, when you speak about optimization, you have to consider the comorbidities, as was said by Armand before. Patient with diastolic dysfunction and a community-acquired pneumonia, of course, is at high risk, do not tolerating fluids. And the source, of course, is not the same peritonitis versus a community-acquired pneumonia. The emerging concept of fluid tolerance, where you will have to probably in the future assess the risk of fluid intolerance, even if the patient is fluid responsive, before giving fluids, if the patient is hypoperfused. Hemodynamic phenotypes, because it's not the same a patient with 80-60 versus 80 compared to other that has profound vasoplasia and has 80-30, where the introduction of early norepinephrine in this context, the heterogeneity of the patient, more intellectual, would say, the uncoupling or coupling of the macrocirculation with the microcirculation, thinking that maybe even if you are fluid responsive, you will not give fluids. Probably if you are uncoupled, you can make things worse. Safety rules, which is the perfusion target, systematic assessment and fluid responsiveness, the triggers, etc. So everything of this you have to consider, for example, when planning a trial to try to define which is the best way to optimize resuscitation. Just a few examples. It's not the same, the target that you use for fluid administration in the ICU in the optimization phase, because the targets have different kinetics of recovery. Even in survivors, there are some targets that normalize in 30 minutes, others take hours. So if you stop resuscitation in the first one, you will stop earlier and you will be more prone to avoid the risks probably of over-resuscitation. And this has been shown again and again. More recent physiological study, for example, showing the rapid response of capillary refill times, to, for example, for a fluid challenge. And the fluid responsiveness assessment is our duty and our responsibility to optimize, not to improve outcome. Of course, we haven't demonstrated that, but maybe to optimize the fluids. In the Andromeda Shock 2, one study, in this post-hoc analysis, we recommended, by the way, a systematic assessment of fluid responsiveness and provided the centers with an algorithm for different situations. You know, there's not so easy as in the papers. And it could be determined in 82% of the patients, of which 1 in 4 were already fluid unresponsive when they started the protocol. They had received a median of 24 mL per kilo previously in the emergency department. So this is unexpected at the beginning, at the admission to the ICU. And these patients, according to our algorithm, were treated, of course, non-fluid responders received 0 volume during the intervention period. And at the end of the road, at the end of the intervention, they received 1.5 less liters of fluid. And, but they achieved the same amount, in the same percentage, the target assigned, because they went for it by other means. So systematic assessment of fluid response could aid in trying to optimize resuscitation, as well as, of course, considering the hemodynamic phenotypes. If you randomize patients to include in a trial, for example, liberal versus restrictive, and you do not consider that some patients are with profound vasoplasia, and they are, for example, assigned to the liberal, then you will get a lot of fluids, and then before you realize that the map will not increase because the problem is vasoplasia. So this is also a challenge. And this is also, I think, a very important slide. Because of the lack of many randomized control trials trying to address this subject with this view, the challenge is how to include all these considerations into a feasible, practical, simple, ideally, interventional algorithm, and demonstrate its superiority over what? Standard or usual care? For example, if we compare with usual care or standard care, of course, standard care has changed over time. I mean, we are in a more restrictive era than 20 years ago. So the comparator will be, of course, administer less fluids. And this is a problem, because the problem is that you will have to show a gradient of interventions between the two groups, the interventional with this idea of optimizing fluids versus the usual care. There will be difficult to plan such a study. So these were ideas that were discussed in the group sessions. Also, our first PICO question was liberal versus restrictive. And when we searched the literature, there are very nice studies. The Clovers and the Classic, for example, which are very important studies, very well performed, very well conducted, and that give pieces of evidence for the general conception of the problem. And I, of course, congratulate all the authors, because it's not easy to do this kind of study with 1,500 patients, etc. The Classic is not only this Classic study. It was preceded, as you know, by a pilot and post-hoc analysis of the pilot, and then post-hoc of the second, etc. So it has a thinking. And they approach the problem just by one view, let's say, liberal versus restrictive. This is one way to approach. And as you know, the study was negative in terms of mortality at 90 days, but they also could not demonstrate any toxicity or serious adverse events, more serious adverse events in the restrictive group. I say this because I think everybody in the audience would agree that if we can be safely restrictive or safely rational, giving less fluid but more well-conducted fluids, it will be better. But we have to demonstrate that this is valid. So this is an approach. And this was followed, as you know, by a recent updated meta-analysis which showed that they found no difference in major outcomes. So finally, because of this is, again, provisional preliminary recommendation, have to be validated for the whole group, of course. For adults with sepsis or septic shock requiring fluid resuscitation, we are unable to make a recommendation for or against systematic, restrictive, or systematic liberal fluid administration under this criterion, because in these randomized studies, the intention of both arms, let's say, led to similar effect on important aspects. Are classic results generalizable? This was discussed, of course. Can we say with the design of the study that it is absolutely safe and recommend for the world that they should go for restrictive because it's the same? I mean, of course, there are some concerns that were expressed. They are arguable, of course. Many people and the authors would think different. And this is, of course, it's science. The high background mortality, maybe the rationale for fluid administration criteria, which were of extreme hypoperfusion in the restrictive group, lactate more than 4, modeling, MAP less than 50. There was no systematic assessment of fluid responsiveness. The target for fluids were not very clear. In my opinion, there were very scanty data about hemodynamics aspects as norepinephrine dose. But the main doubt, and I share, and there was discussion, of course, in the group, is that eventually the neutral effects could be the counterbalance, or maybe some patients were harmed because of this extreme hypoperfusion criteria selected, and this counteracted over the benefits. So, but this is arguable, and this is why we finally came to this, that we cannot recommend either systematic or either for this reason. And of course, the next question was individualization. Could we recommend individualization? And we have to acknowledge that there is no evidence whatsoever, except whatever, I mean, I don't know how to call it, common sense or physiological thinking, but there's no evidence if the addition of specific perfusion targets, systematic fluid responsiveness assessment, the use of hemodynamic phenotypes to guide whom I get fluids or not, you have no data available. We could call them perfusion-targeted studies, show it in some more fluids in rivers, in others less fluids, and but they are not, let's say, designed to assess really the individualization. But they shared only that they had a perfusion target. And the systematic inclusion of fluid responsiveness assessment has been tested in some studies, post hoc, etc., but without, when the methodologists did a sort of meta-analysis, they found no signal that it favored at least mortality, although it may be useful to optimize in the sense that avoiding fluids in patients that are obviously fluid unresponsive. So finally, the conclusion was that for adults with sepsis or septic shock, we suggest with the extremely very low quality of evidence and a conditional recommendation, individualization approach over the optimization, but with a big depth in designing studies with all the complexities that I showed to address this problem in the future, because the personalization is our responsibility as researchers. We have to have the mind, the consensus to try to figure out studies that go in this way. There is a small hope, probably, in the Andromeda shock study that is almost 800 from 1,500 patients recruited, that includes some of these aspects to try to individualize better the study. Thank you very much.
Do we have questions from the audience? Glenn, just a point, just to clarify. If I understood well, the recommendation is that we were unable to make any recommendation for or against, and not that we are recommending not to do either liberal or restrictive
Exactly.
strategies, systematic liberal. Can you comment on that? That we were unable to make a recommendation instead of we are recommending either systematic.
Yeah, because
one or another.
I mean, there was discussion, as you know, but I mean, I think the majority view was that if we said, for example, we recommend using either liberal or restrictive, it would, because of the immaturity, let's say, of the background concepts, and because this gives only a window, I mean, a tubular window, is an approach that has some of the things, of course, but the whole picture is not captured. So it would lead, if given that way, to probably to in some settings to use liberal. No, I use liberal, and then I give liberal to everybody, and then this could lead, of course, to harm in some patients. This risk balance is yet, for me, for the majority, it has to be better defined in future studies. This is why, finally, we choose to say we are unable to make a recommendation, not against, but as you said, unable. I think this is fair. At least I feel so.
And by the way, it's the same for the ICM RDS guidelines, where indeed for the PEEP level, even though there are multiple trials of very high quality, the final recommendation over PEEP is very difficult to make any recommendation, and so also they refrain to make a recommendation about a higher or lower PEEP. Yes, one question there.
Hi, Philip Bauer from Mayo Clinic, United States. Glenn, I enjoy your talk as usual. Thank you. I know that this is a based evidence protocol, but my question to you is with the 1 hour bundle, which is more and more used, meaning early initiation of vasopressor, even before all the fluid is given, how relevant do you think the resuscitation and the fluid responsiveness will become in the future?
I mean, I think, of course, there is pending big randomized controlled trials about the use of early norepinephrine, especially in the hemodynamic phenotype of profound vasoplegia. I mean, you have to, if we finally end up with a randomized controlled trial where the only criterion to be included is a MAP less than 65, then we are lost, because we will have to try to define populations a priori that could be benefited, of course. But how do I see in the future? There are so many uncertainties, I think. Aquí, there is a call for further research, of course, and to make things more complex. Now there is an emerging concept of fluid tolerance, and I think that in the next years, you will have risk criteria to figure out before giving fluids, even if you are fluid responsive, even if you have hypoperfusion, even if you have in your mind increasing systemic blood flow, you will probably be cautious because there are some fluid intolerance criteria that have yet to be defined. So I think that what things that are going to be valid still is the fluid challenge. The fluid challenge involves a responsibility to select the right target, to assess fluid responsiveness before, because you have to know in which part of the Starling curve is the heart of the patient, etc., and selecting the right target and stopping and have safety rules. This will not change, I think, because this is classic and is established. But what to do? How much fluids how many cycles can you give, for example, before performing a formal echo to rule out, etc., severe left ventricular dysfunction, etc. There are many things that have yet to be established, but I think it's a matter. It's challenging, but it's also amazing that we have this duty, all the trialists, the researchers, to try to design these studies for the future.
Thank you very much, Glenn.